Assalamu alaikum and good evening to you all. Welcome to the 10th episode of Health Talk, powered by SCP Bangladesh Chapter and supported by Bangladesh Society of Medicine. I am Dr. Prince Kausar. I'll be hosting the show tonight. On today's episode, we will discuss about the most talked about topic of the time. So don't miss any part of today's program and invite your doctor friends or colleagues to join the program with you. The speaker of today's program is an immensely renowned professor of our country. He is none other than Professor Amin sir. He is the line director of NCDC, DGHS and Secretary for Research, Bangladesh Society of Medicine. He will be discussing today on current status of COVID-19 pandemic, virus to vaccine. And as I already told, this is the most talked about topic of the time. As the chairperson, we have undoubtedly one of the best physicians of our country, the core behind this health talk program, Professor H.A.M. Nazmul Ahasan sir. He is the current governor of SCP Bangladesh chapter and the head of the Department of Medicine and Professor of Medicine, Popular Medical College. We also have Professor Muhammad Ismail Patwary sir as the panelist with us. He is the principal and professor of medicine, Sylhet Medical College. He is also the president of Bangladesh Society of Infectious and Tropical Disease. We also have Professor Dr. Abdul Kalam Azad sir as another panelist with us. He is the former head of the Department of Genetics and Engineering, Shahjalal University of Science and Technology, Sylhet. Today's program will be moderated by our very own Dr. Rafiqul sir. He is the Associate Professor of Medicine, Sohit Sohrawardi Medical College. During the live session, you can ask topic-related questions in the comment section. We shall try to answer them on the question and answer session right after the presentation. So, without doing any further delay, let me hand over the session to Dr. Rafiqul sir to moderate today's program. Dr. Rafiqul sir.
Greetings from SCP Bangladesh chapter. Welcome to the Health Talk program episode 10. And the program is organized by SCP Bangladesh chapter and supported by, as said by Dr. Prince, the BSM, Bangladesh Society of Medicine. Today, Honorable Governor of SCP Bangladesh chapter, Professor H.M. Nazmul Hasan sir will remain as the chairperson of the session. And there's two renowned professor. The first is respected Professor Ismail Patwary sir, who is principal and professor of Sylhet Women's Medical College, who will remain as a panelist, and as well as Professor Dr. Abdul Kalam Azad, former head Department of Genetic Engineering and Biotechnology, Shahjalal University of Science and Technology, Sylhet will remain another panelist. Regarding the speaker, we have with us Professor Dr. Muhammad Amin sir, who is most legendary professor of medicine and now appointed as the line director of NCDC DGHS. Whenever sir talks regarding any topic, we remain amazed and listening to his presentation. So I will request sir to present his topic, which is current status of COVID-19 pandemic, virus to vaccine. So without any delay, I will request my mentor and honorable professor of medicine, Professor Amin sir. Sir.
Thank you very much, Dr. Rafiqul Islam, our very dynamic Secretary General of the ACP chapter of Bangladesh. I'd like to give my paid tributes to the ACP chapter of Bangladesh for inviting me to give a talk, especially on the health talk on the part of current status of COVID-19 pandemic, virus to vaccine. Our Honorable Chairperson, Professor H.M. Nazmul Ahasan sir, Governor of the ACP chapter, our very dignitary panelist, Professor Abdul Kalam Azad sir, Genetic Engineerist, and also Professor Muhammad Ismail Patwary sir, a very dignified, honorable teacher of our country. And I also give heartfelt thanks to all the listeners and participants who are actually listening on this important topic, virus to vaccine. So this is the topic that has been scheduled to give it to me. And I was very amazed to say that how much time actually I will have, because when you start from the virus and now last to the vaccine, it should cover everything. But it will be very difficult for anyone in this COVID-19 pandemic, after such amount of infodemic, to say something within a very short sphere of time, having such a large impact of the virus in the total world. So what I like to state that I will be given a very precise, important information on the part of virus, a small to start with. Then I will be given some of the important consideration about the therapeutic options. I'd like to give a pen picture on that part. And later on, I will give a small talk on the part of these vaccine. So this will be my schedule of the lecture. So let's start, I think, about the current status of COVID-19 pandemic, virus to vaccine. Gentlemen, ladies, you all know that whenever a new pandemic situation happens through a viral infection, we always become interested in the part of
Sir,
epidemiology.
yes, sir. Can you please, sir, put it in the presentation mode, sir? So can you make it larger? Yes, sir. Yes,
Yes,
sir.
thank
Thank you,
you
sir.
very much, Prince. I think right now everything is clear. Now, the fact that it started with epidemiology, this is an old picture actually. What I like to mention is that this pandemic situation, the virus, always people's mind keep two things. What is the new case that is happening, and what is the death, and who is actually having the risk? So this is how the many of the scenarios has been explained in the COVID-19 through the SARS-CoV-2 viruses. We are calculating from the January to complete December, and then again started the January 2021 about the new case and death. In the meanwhile, there has been many of the risk things that happens to show who are actually getting the death. It can extend from the meat packing plants to the nursing to the seriously risk factor groups to the ship crews. And still, the new things are evolving as the days goes along. Now, the last scenario, every presentation usually happen to see what is the situation of our country and what is the global. I always started with my country perspective. And you can easily see with an addition of 890 cases today, we are accumulating 524,910 cases. And with an additional 14 cases of death today, we are having death of 7,833. Although it's very pleasure for us to know that the death rate of our country is 1.4%. But remember one thing, as the number is accumulating the months along, look at the number, it goes to 7,833. This is not a scenario that we can give a easy example of the breathing situations when we are counting deaths as the days go along. Good news, yes, definitely. With the additional 841 recovery cases, we have total amount of recovery of 4,69,522. While saying this, I am really surprised to see the global case scenario. It's just crippling up and up and up. In this January 14 of the 2021, you can see that we are accumulating about 9 crore 23 lakh 13,199 confirmed cases and having a death around 20 lakh people. Their recovery rate is good, but being saying this, we are also seeing the number of death is not less than 10,000 in this time of winter. On the right side of the winter, I just say give an impression of this picture of Bangladesh actually, and not the global one. Why? Because in these epidemiological contexts, many people are very much concerned. Are we having a second wave? Are we having a three wave or third wave? So I just put at the front checks from the very beginning to the last end one. You see, we are having the wave that is going on up and peak, and when it goes down, it gets another peak, and then again it goes down again another peak. So we cannot just simply say that first wave gone and second wave comes, or second wave gone and third wave comes. All we can say is that our wave is going on and on and on, simply because that we do not test too much of the cases to identify actual case scenario of our country. While in the meanwhile, we're passing through the first wave, the second wave or the secondary phenomena of increasing cases has been observed. Now, about the virus, I think this is the most important part that I was talked. Now, we all know that it's the name of the virus has been said as SARS-CoV-2, simply because there was another SARS-CoV in the 2004. And this is the pen picture of the scenario. The electron microscopic picture can give a large dimension of the virus with such amount of macronodal structure over there. But believe me or not, we cannot see these things in our lifetime. This is the virus that is completely invisible when we are seeing things in the front of our eyes. But look at this beautiful picture having the spike protein. All we know that about S1 and S2. This is the ACE2 receptor of angiotensin converting enzyme, which is situated not only the part of the lung, but also the blood vessel, and so that if the blood vessel traverses all along the body, we can say that the virus SARS-CoV-2 through this ACE2 receptor can involve any organ of the body. and henceforth, the disease is now known as the multi-system disorder. Most important part of the virus is the part of the spike protein in the form of the S1 and S2. Now remember, this one S1 is actually having a specific area known as the receptor binding domain through which it can combine with the AC2 receptor for an entry to the part of the cell. And it is a very good amount of fitting. Well, when it fits actually, this fit portions of the virus is known as the prefusion viral protein. Now, this prefusion viral protein is so much important because when it combines, there are other protein comes up to the side so that an easy entry to the cell can happen. Those protein has so many names, like as the TMSS protein and others. So when they have a large amount of binding for the entry, it does not have any domain to be known as the prefusion protein. It named as the postfusion protein. Why I'm saying this? Because if you consider about the prefusion protein as specific entity, then you can have some of the mechanisms through some of the signs to make it binding and make it inhibit. And that is the reason this spike protein having the receptor binding domain in the prefusion pattern is the target for any vaccine to develop. So that's the reason why I'm showing this in a very larger frame. Well, in the meanwhile, you can see the virus so beautifully location, and within this part of the nucleic capsid, this is the main area of the protein or the messenger RNA. And because this messenger RNA is responsible for getting an entry and going for the replication of the virus into a multiple copies. So this is a big area where we can target also to have this vaccine successfully applicable for the inhibition of the virus. So these two things I like to give sharing to everyone so that we can keep our mind when we consider about the vaccine. An overview, I will say that this is not the first coronavirus that we have been seeing. We all know that. There are 7 viruses that has been pathognomic for the human being. And one of them was deadly in the territory of 2000 to 2003, known as the SARS, that was extended from the China to Toronto. And there was 8,000 cases with case fatality rate of 9.5%. Similarly, another beta coronavirus in the name of the MARS has been resolved in the 2012 in the Saudi Arabia. And it was saying that there was a 2,260 cases with a small cluster since then, but having a case fatality of 34.4. While in this meanwhile, this time it started from the Guangzhou of this SARS-CoV-2 virus, having a China to be started in Wuhan, and secondary attack rates of the pre-symptomatic cases has been evolved since the December of the 2019 and goes on and up to 2021 also. So this is the publication that has been shown that in that pre-symptomatic cases, 16.1% household has been suffer from this illness, 1.1% having some social contacts, and workplace contact was very low initially. Now look at this one. This is the genetic frame that I like to mention about the protein that is developed from this genetic code. And this genetic code has the S1 and S2, which is the actually part of the S1 protein. And in the meanwhile, if somebody has to tailor end of the other genetic profile, it will be looks like this. And since the virus envelope is the most important factor, the genetic code has been different in the alpha coronavirus group, in the beta coronavirus group, in the gamma coronavirus group, and the delta coronavirus group. In these virological papers, the beta coronavirus has shown the propensity of this binding capability of the S1 virus in their genetic code. And on the right side, you can easily see how the things are actually with the color binding, showing the actual binding and the trim effect of the S1, S2, and showing by the scissor here, which is very crucial for the importance of the getting entry of the virus into our cell. Now, why I like to say that this is the genetic tree that will be more interested by Professor Abdul Kalam Azad possibly, to see the evolution of this genetic mapping of the SARS-CoV-2 virus, since it started from the Wuhan up to the VU virus territory that developed in England or the United Kingdom. Now, what we are seeing is actually the world is now dealing with a different type of SARS-CoV-2 than the one that has emerged in the China almost a year ago. And this is the time where we are saying that mutation actually is creating at least 7 strains of the virus so far. So this is one other publication what I like to say. What I like to share with all of you that why I'm saying this 7 strain. I'm seeing it is by means of major grouping in the color. You see in the red side of the color, this is the Wuhan when the January 1 actually shows the strain was named as the L. While it was transmitting all through the part of the China, a new strain known as the S came up. And within S came up, then the yellowish portions known as the others for the O came up, not only the part of the China, and it becomes to transmit to the part of Europe and the United States of America. And suddenly the new color changes into V. And later on, the mutated strain known as the G, all the strain later on started from the G to GR, GH, and GV are nothing but the G type of strain. So you can see right now, whole globe actually is showing the mutated strain pattern of G and their variants in this particular one of the SARS-CoV-2 virus. That's the reason why GISH says that it starts from L to S to O to V to and G, and there are subgroups known as the GR, GH, GV. And you can see around the globe, case 1 started with the red one. And you can see and compare the color, how it turns them into S pattern, then how it turns into others, then how it turns into the V type. While in the meanwhile, the later on the part actual virus sample, when it taken with relationship, found all the strains come with the G. So you can easily see that the latest version of this one, either from here or there, all are belongs to the part of GV. Now, the geographical distribution, if you can see, of the virus, I was to look at this in the Asia, North America, Europe, Oceania, South America, and Africa. Wherever you go, these colors are actually all are territorially predominating, and these all are the G pattern of virus. So you can see, although there was in the Asia, which is having even in the November 3 with other type of virus in the meanwhile, as with few areas where it has a pickup, but most of them it still remains in the part of G mutation that is leading. But look at the other maps. These all are G and their variant. While in the meanwhile, we are having some problems, which is actually the problems occurs in the United States and India, because these two areas having the largest case load around the globe right now. And you can see GH, GR, and G variant is also predominating. What about the new strain, which will be explained by our Honorable Professor Kalam sir, probably after my talk? He says that it's called the BUI, means that having an interest in the part of new one. And naming of that virus is 2020-12-01. And they say that when this United Kingdom having a cant area is showing the news variant, are these a different type of strains than the G? It actually remains on the part of G variant. And the deletion also has been shown to be responsible of new getting the mutation is N51Y to 69 to 70 deletion. So you can see there are so many mutation actually happens in the viral territory where there's a changes of the transmissibility, and that leads to the more amount of infection. So how many mutation we have actually had found since the very beginning? In one of the paper, they said that about more than 12,700 mutation happens in the SARS-CoV-2 virus, which is basically a 30,000 nucleotide long loans. And when we are considering about where it does causing the mutation and a name, this is the name that has been set. We all know something about the D614G, but right now there's another variant known as A222V becomes a responsible mutation causing the troublesome effect all around the globe. I will be stopping the something saying about the virus right now and switches over to a only slide for the clinical course. My impression is that this slide is so much important as because when we are considering about the COVID-19 pandemic infection, we divide the patients into certain phase. One phase is called we are early infection phase, when the virus is actually replicating so much high that you can have some sort of illness in the form of the respiratory symptoms commonly, and sometimes other systemic illness symptoms. like in the form of the fever, like a systemic onset of the malaise, body ache, and others. Sometimes in the territory of not having any smell or the taste, some of the patient can have a GI symptomatology. But whatever it is, it remains in the early part of infection. And later on, the stage two, when the pulmonary phase started, this is the big area because in that area, the viral response phase is accumulating, having the host inflammatory response at the same time. Later on, as the days goes long, the host inflammatory response came up, leading to some of the patient having a hyperinflammatory phase. That is the dangerous phase where people are dying, not only from the part of the ARDS, but can also have die happen from this part of shock syndrome or maybe a cardiac failure. So, gentlemen, ladies, what I like to mention that the clinical symptomatology can be started from here, where we can have a only mild constitutional symptom in the form of fever, dry cough, diarrhea, and headache, maybe. But later on, as the time comes over here after a week, it started to having some breathlessness and hypoxia leading to the danger sign happens in these overlapping phases, followed by, if it happens to go for the stage three, the dangerous scenario of the death and life remains there. How many signs we can have depends on the which phase we're actually seeing the patient. And the investigational tool also be having variations in the stage one to stage two to stage three. So you can see the lymphopenia will be a very important sign in the stage one, while abnormal chest finding will be an excellent finding in the stage two, either by means of the chest X-ray or CT scan of this. You can also have other inflammatory marker in the form of the transaminitis as well as the low procalcitonin. While in the meanwhile, hyperinflammatory phase will have all the cytokine tsunami or the cytokine releasing syndrome. And remember, if we consider about keeping in mind or brain about all these three stages, we can also have judge what potential therapy can happen to work on this part of early infection or the late infection. As the virus is replicating so much high in this early infection, you'll be always consider, can we give some of the antiviral drug like the Remdesivir? Can we give some of the drugs which can give some of the antiviral effect in the form of chloroquine or hydroxychloroquine? Or can we give something of the drug like the convalescent plasma transfusion or not? But if we consider about the staging is in the stage three or two, forget about those antiviral effects. Rather, think something which can emulate or the host inflammatory response in the form of immunoglobulin, maybe some of the DMRD groups of the drug that has been in the immunology, or maybe some of the JAK inhibitors should be in our mind, rather than this early sign of the Remdesivir and other groups of drug. So this is very important to consider about the clinical courses in any patient with the COVID-19 so that we can see the inflammations as well as the symptomatology sign and the relationship with the potential therapy in this respect. I will be giving more precise importance on one disease known as the COVID-19 moderate disease. Why? Because when somebody is having critical illness, it's very difficult to judge whether can it be human be successful or not against the death or life. But if it is a case of the mild to moderate disease, there is every option that you can intervene and stop the virus. So stopping the virus, if it is keep in mind, we should concentrate on the part of moderate disease because it has been proven that the mild cases does not have any severity and mild cases mostly actually resolve on its own. But it's the problem of the moderate cases, you will be never be sure whether it will be turned back to the mild or can be turned back to the severe or not. So that is the reason why there has been saying that can we target these groups of the patients earlier so that they will not transform into the severe as well as critical illness. So that's the reason some of the patients of the moderate group still needed hospitalization for observation as well as intervention. And we also can have some early data for the COVID-19 therapy so that the referral to clinical trial is very critical in this respect of these groups. While in the meanwhile, we always all in every specs of the group having an infection control measurement in the form of PP for the healthcare worker, distancing at the same time testing. Well, about the therapy, what I like to mention that there has been no doubt about the importance of the oxygen in any patients with COVID-19 having severity. Means that the patient who is hypoxic, the primary point of therapy is oxygen. I'm not going to give you a detail on this part because it will take another classes to go on. Another point that has been very recently came up in the mind that anticoagulant has been found to have enormous benefits, especially those patients having some risk factors, especially if the patient is still in the mild to moderate cases. As because we know that having a risk factor in the form of acute illness, bedridden, or the diarrhea, having some diabetes or hypertension or CKD or any other risk groups, there has been a big issue that whenever something having the hemostatic abnormality happen, it leads to the clinical outcome in the form of venous thromboembolism, myocardial infarction, and even the disseminated intravascular coagulation. So anticoagulants will be an excellent beneficial drug for those patients having such amount. I will be giving some of the pen picture on the part of the antiviral drug, especially on the part of remdesivir. You all know that it's a prodrug of the nucleotide analog inhibitor of RNA-directed RNA polymerase, which is important for replication of the messenger RNA of the virus for its multiple to multiple copies. Now, it started to from the remdesivir in their compassionate use. And the compassionate use, which was not a randomized control trial, actually initially shows there was so much clinical improvement in hospitalized patients, about 68% from the severe COVID-19 group. And that is the reason why the remdesivir started to bring up in the field where it was totally absent even in the 1 year back. Now, since then, it has been used as an emergency use of authorization, approval by the means of FDA. But later on, some of the trial came up. One of the clinical trial came up is from the China, which was actually a randomized control trial, and it was shown that against the control, it did not have any statistically significant benefit. But in that trial, you can see in this picture, still, if somebody has a duration of illness less than 10 days, then the remdesivir had been shown to have faster time for clinical improvement. But the big problem of that study was the side effect profile. About the 66% of the cases of the remdesivir actually treated patient having so much side effect that they had to even think about to stop the drug in the meanwhile. As the China has been shown that control of the COVID-19 at that time, so they did not reach the sample size attainment by means of remdesivir study, so they stopped the trial at that time. Now, this is the trial that has been shown that tremendous amount of hope for the human being in the naive adaptive COVID-19 treatment trial, which actually allocated 538 patients with remdesivir against the placebo. And you can see it shows the benefit against the placebo of the shorter the durations of the illness. But in the meanwhile, in the same paper, actually mortality was found to be have 7.1% the remdesivir and 11.9% the placebo group, which was not statistically significant. And interestingly, serious adverse event was also found more in the placebo group rather than the remdesivir. And although it was found to be a superior in shorter time of recovery, it does not have actually any impact on the part of mortality or ventilation. Now, I would like to give another trial known as a simple trial of the COVID-19 in the severe group of the patient, which was actually not a randomized control trial, rather it was an open label trial. And these are the very serious patient actually who has given the remdesivir to show whether any benefit happens or not. Now, look at this right-sided picture. What I like to show that as the days goes along, especially when the patient was having ambient air and the low flow oxygen, the number of discharge was very high in the remdesivir group. You can see this one. Fantastic. But when some of the patient was having a high flow oxygen, the discharge was very low. And look at this number. These are actually the serious cases is basically increasing. While the patient was in invasive mechanical ventilation, even the discharge from the patient was even low. And in between the 5-day and 10-day groups, we did not find any very basic difference. So you can see a patient having an hypoxia of COVID-19, the actual benefit was given when the patient was receiving the low flow oxygen rather than high flow or invasive mechanical ventilation. This is to be keep our mind Because when we are selecting a patient having a remdesivir, we must keep on our head that a patient has to be getting the hypoxia, but he should be in the part to getting low flow oxygen. Means that you are getting the oxygen in the territory up to 6 liter to 10 liter a baby, not below, above that. If any of the patient who need a high flow one, you will be never sure whether remdesivir is going to affect or not. What about the last one? And the WHO actually in the Solidarity trial says that remdesivir fails to prevent the COVID-19 death in the huge trial. That's a huge number of patients has been allocated from the different countries of the globe, and which actually shows there is no excessive amount of benefit in the death or by means of invasive ventilation. But remember one thing, even in that Solidarity trial, the low flow oxygen, you can see the benefit was given for the patient having a remdesivir. But this study actually has been so many criticized by as because it has been said that as the WHO has doing the study in different countries, it was actually poorly conducted in many of the countries to say this definition to be definitive. Another thing is that you can see the rate ratio for death was means by means of 99% confidence interval. Well, in the meanwhile, when we analyze the cases, we actually follow the 95% confidence interval mostly. So some of the critics say that if we consider about the 95% confidence interval, maybe remdesivir would have given more benefit. We all know about these risk factors about the severe COVID-19 infection. I'm not going to say anything about that one, but this is true. These are the groups of the people. We must be always be cautious, be careful, and be very vigilant. In even this should be hospitalized for even observation according to the last 1 year's observation around the globe. This is the one what I like to give in the pen picture on the timeline of the symptoms. This is very important as because I told you the most of the time when the virus is at peak, it usually is causing the mild constitutional symptom rather than the dyspnea. But look at the dyspnea in 40% of the symptomatic phase happens after 7 days. So this is the area where we must be cautious. For any patient with the COVID-19, even for the mild to moderate, whatever symptom he has, we say that look after very carefully on the 8, 9, 10 these days. Because this is the area where some of the groups of the people will have severe illness in the group of 14% and 5% we all know that go for the critical issues. So why I'm saying this, because since then there has been many experimental treatment strategy can be going on against this virus. One thing is that if we consider about the addition of virus to the receptor, we can target this one by means of convalescent plasma or the new onset of monoclonal antibody. If we consider about the TMPRS receptor which needed for the entry of the virus, we can target by means of chemostat mesylate. If we consider about the getting entry of the virus and endocytosis, we can also target by means of chloroquine, hydroxychloroquine. And even though the virus can get an entry and the translation can happen, we can also give some of the drugs like the Lopinavir-Ritonavir groups to get a cleavage in the part of polypeptide, which is essential for developing these enzymes. And later on, we can also target these virus in the form of messenger RNA by remdesivir or other antiviral. And again, when we consider about the viral protein to develop from the part of endoplasmic reticulum to the Golgi apparatus and also the virion release, there are many areas we can also target it to give a treatment, like target the translation, target the packaging, target the virion release in any of the site. I can have a territory so that we can target the virus. So considering for the COVID-19 clinical trial design, we must consider a few things. One is what is the timing of the virus during pandemic? What are the agents that we need to go for the study? What will be the choice of control arm? What should be the master trial design? Can it be an adaptive trial or not? And also we can see the things like the clinical trial capacity and vaccine to develop within the short period of time. And that is the reason why within a short sphere of time in the preclinical to vaccine, there has been many of the study has been done globally against this pandemic COVID-19 during this last 1 year. Few of the things that I like to mention, there has been much of the controversial issue of the hydroxychloroquine. Few of the observational study has been showing to have benefit, But small randomized treatment trial actually shows there was no benefit there. There was a multiple prophylaxis protocol has been done. A large prophylaxis protocol has been started in the England and still is carrying out. And interestingly, a Lancet paper, which actually shows the inclusion of 90,000 participants, has been retracted from this very prestigious Lancet because of the data integrity. So you can see in these COVID-19 groups, what can actually happen even the science is going so smoothly. There will be always questions about the integrity of the science when such thing happens. And also there are question arises about the cardiotoxicity. When hydroxychloroquine was given the very high dose, and the QT prolongation lead to mortality has been shown in few other papers. In those studies, actually, it has not been found to have actually very beneficial effect on the part of hydroxychloroquine. You can see that one on the right side. And last of all, what I like to say that many of the randomized control trial study actually doesn't show any benefit. You can see the forest tree, it shows this, all the rhomboid shape crosses the midline. So we can safely assume that in the therapeutic portion, a hydroxychloroquine study actually fails to show the benefit in this pandemic COVID-19. What about the Lopinavir-Ritonavir? You can see, although initially one of the open label trials shows a marginal benefit of Lopinavir-Ritonavir over the control, but whenever the randomization happens against the standard of care, it was not associated with any clinical improvement. You can see hazard ratio is 1.31. So that was the reason why another study came up with the outcome over time from the nasopharyngeal. Means that when somebody was giving lopinavir, ritonavir, and ribavirin, are we having some clearance of the nasopharyngeal of virus load or not? Although it has been shown the combination has a beneficial effect, symptoms were elevated, a shorter duration of viral shedding, but the clinical outcome was not very much beneficial in the severe group, but rather only the mild to moderate group. What about the other targets? I told you a large portion of the cell virus can happen of receptor binding entry, having immune activation by means of macrophage and lymphocyte came up in the territory of the cell that is infected by virus. So that the scientists started to believe we can target so many areas, like we can target in the part of the epithelial site binding, if we consider about giving the chloroquine, hydroxychloroquine, even though early part of immune activation can be withheld by giving baricitinib, the immune activation can be withheld if we consider giving the leflunomide or thalidomide. And even though we cannot hold these things, macrophage and lymphocyte will come up to release so many cytokines in the form of IL-6, MCP-TNF. We can hold this up if we consider to give tocilizumab or maybe anakinra and others. So you can see that is the reason why many of the agents actually known as the immunomodulation has come to the experimental study for the treatment of COVID-19, starting from the chloroquine up to the ruxolitinib and baricitinib also. Now, is there a benefit of the immunomodulation? The answer is yes. The best study came from this preliminary report from the dexamethasone in hospitalized patients with COVID-19. We all know that it's the recovery trial. And look at this one. It's a fantastic study, and it shows that the benefit was tremendous when the patient was invasive mechanical ventilation. Look at the benefit. And look at the mortality reduction. 29.3 versus 41.4. Just as tremendous. And look at this, not only the part of having an invasive mechanical ventilation, the patient who received the oxygen, look at the benefit of the mortality by dexamethasone. And interesting patient, when they consider about all patients participant, the dexamethasone shows the benefits yet. But at the right-hand side, the usual care and dexamethasone, if the patient does not need any oxygen, it completely reverse. You see, dexamethasone on above and the usual care below. So that is the reason why what I like to mention, please do not give any dexamethasone to any patient who does not need any oxygen or respiratory support. This is the initial recommendation from the dexamethasone group of the drug, which has not been in the mind of our many physicians of Bangladesh. About the tocilizumab, we know that what is going to be happen by means of IL-6 receptor inhibitions, which is important part of cytokine storm or not. And that is the reason why tocilizumab was giving a lot of study. 6 studies has been completed by means of tocilizumab. 5 of them have shown no benefit at all. But later on, the last study, which actually has been published, says that tocilizumab is actually have some effect in the part of invasive ventilation groups of the drug having severe groups of COVID-19. So the judgment whether the patient has got early part of the cytokine releasing syndrome can have some impact on the part of tocilizumab by means of later study. This is the IL-1 inhibitors, named as the anakinra. A small study actually showed its benefit. As because the IL-6 inhibitors in its one randomized control trial shows benefit, it becomes again an interest whether can we also provide the anakinra in some of the patients, even in the trial for patients having severe COVID-19. What about the recommendation? I would say that CDC giving a panel recommendation very recently, which is very important for us to identify. One thing is that those patients who is not hospitalized or even hospitalized but does not need any oxygen, this panel actually says that do not use dexamethasone. But you cannot give a recommendation on the part of specific antiviral immunomodulator therapy in this group. But if the patient is hospitalized and require the oxygen, please give him remdesivir if he does need a low concentration of oxygen. And you need to give the dexamethasone and the remdesivir both if the patient need a high flow oxygen. And dexamethasone to be provided to patient who need oxygen in the hospitalization. This is the rules. So any patient who hospitalized and require oxygen delivery through either low or high will receive the dexamethasone. But if the patient receives the low concentration of oxygen, then the remdesivir will be highly beneficial. If the patient require oxygen delivery through a high flow device, then dexamethasone is a rule. But you can also consider to give a dexa plus remdesivir in this group of patient by seeing the patient individual judgment. For any hospitalized patient who require the ventilation or ECMO, dexamethasone is the rule. But you can also consider to give the dexamethasone plus remdesivir, and very recently about the baricitinib, if you consider an individual judgment. I will not say many things about the convalescent plasma. The last recommendation is that if any patient is getting hospitalized, need oxygen, remain the hospitalization within first 48 hours is a good candidate to convalescent plasma. But after that, the efficacy of the convalescent plasma is a big problem. And still, there will be much more to come, like the lambda interferon, favipiravir, chemostat, nebulization, the remdesivir, maybe combination therapy, which will make it come to part. I will be given another important consideration to say something about the monoclonal antibody, named as the bamlanivimab, which was then seized by emergency use of authorization. They said that consider it only for those patients having a higher risk. And the higher risk means that a patient age more than 65, high BMI, diabetes, kidney, or immunosuppressive agent. Or maybe they have a cardiovascular disease or COPD. So these are the groups where you can consider to give the bamlanivimab, a monoclonal antibody, as a part of emergency use of authorization. And when you are considering these groups of drug, try to give it in the outdoor basis rather than the hospitalized patient. Why? I'm showing it just after the benefit. Now, this is the monoclonal antibody actually. I will not give a detail on that part. What I like to say that when SARS-CoV-2 get our body get infected, our body's immune system makes some antibodies. Now, this is our own natural antibody against the SARS-CoV-2. If we consider to making this antibody in the laboratory, then this is known as the monoclonal antibody. So that's the reason a lab-based monoclonal antibody can have a serious beneficial effect if we consider to give it as early as possible rather than the late, as because virus just get an entry to get an antibody developing in our body in the form of neutralization. And that is the reason why the spectrum is actually happens more in outpatient, early part of inpatient, and maybe prevention. And although there's a risk of allergy reaction can happen from this foreign protein or the lab protein, generally this is well tolerated. Now, is there any trial for that one? I say yes. There are two trials that has been done by some monoclonal antibody. You all know that when Donald Trump, the American ex or maybe overlapping president of the United States right now, has the COVID-19, he received one of the monoclonal antibody combination. They are known as the Regeneron investigational double monoclonal antibody combination, RegenCov2. Now, after the successful event that happened against the Trump, immediately they enroll the patients for the 2,000 asymptomatic adult patients. So some of the patients will receive the Regeneron COV2, while others will receive the placebo. So in addition to the safety, they will see whether they can prevent to getting the infection or symptom or not. So these all trial patient participants will be actually follow up after for 7 to 8 months. Another trial actually has been shown to one monoclonal antibody, bamlanivimab, especially from a recovered COVID-19 patient, it developed to see a trial against the placebo to find it whether efficaciously it can prevent any symptom or not in patient COVID-19. So this is the trial, and as the trial goes on, interesting phenomena came up with the monoclonal antibody, as because it has been shown that the bamlanivimab arm was halted for the lack of efficacy in patient who was actually admitted patient. So it says that the admitted patient having the disease will not get benefit from the monoclonal antibody. And about the Regeneron, dual monoclonal antibody combination study was also on hold in the ICU and high flow oxygen, so that a patient having a severe illness should not be a candidate to receive the monoclonal antibody or Regeneron antibody. They can only be given or be tried in having an outpatient or early patients with COVID-19, where it actually shows some of the benefit. Now comes the last part of my talk, vaccine. You can see one question arises: if Pfizer, BioNTech, and Moderna vaccine came to our country, what will happen? I say that there will be multiple frees has to be buy by our government. You can see the Bangladesh maybe have a lot of freezes at that time if we consider to take out Moderna or BioNTech vaccine in our country. What about the vaccine basics for the students and for the many of the physicians that we like to know that? You can see the coronavirus infection or COVID when I get an entry, it can causes immune response by means of many issues, by means of T helper cell, and then which stimulate the B cell. We all know these things. Why I'm saying this? Because from the part of the entry to the ultimate development of the antibody, there are many steps where we can target to create the vaccine issue to development. And that is the reason why the newer development of vaccine becomes the highlighting importance of the scientists in the last 1 year duration of time. Now, this is the area why I say this, because you will find that some of the vaccine actually targeted the spike protein. And when the spike protein is a consideration, some go back to the part of messenger RNA, which is responsible of developing the spike protein. And so they develop a RNA vaccine. Some of them target in a different way, like replicating a virus and making a DNA protein, leading to the development of this newer concept of the virus vector in the form of developing the virus. So beside this nucleic acid vaccine or DNA vaccine or RNA vaccine, we are also having some of the vaccine which is protein based. Means that one of the spike protein subunit will be targeted rather than total virus-like particle. So about the vaccine, what I like to mention that the old versions of the inactivated virus, killed virus vaccine, or maybe a live attenuated virus vaccine procedure developing is although there, the newer conversion of the DNA vaccine, RNA vaccine, and the virus mediated vaccine becomes the highlighting point of this one of developing vaccine against the COVID-19. I would say the fantastic revolutionary scientific effort has been done in this last 1 year. And the global at the first time shows that how a vaccine started to develop after getting the genetic code in the January 11, 2020, and deployment of the vaccine happens within a 10 months duration of time. Unbelievably quickest time the vaccine has been developed for the deployment in this globe. And this expedite helps all around the people around the globe to become a candidate received against these very deadly COVID-19 viruses. I will be given a small pen picture of the current viruses vaccines that has been shown tremendous amount of phase 3 elements in the published article. One of these is the Pfizer BioNTech. You all know that in that phase 3 study of 43,000 people, there was a 95% efficacy. And interestingly, there was a 170 patient COVID patient developed after getting the 2 doses of the Pfizer BioNTech vaccine. Only 8 of them were having the vaccine, 162 of them were receiving the placebo. 10 of the patients actually had a severe illness in these groups, and 1 was only in the vaccine group. So that is the reason why the efficacy was found to have 95%. And although in the Pfizer BioNTech, 1 severe case was detected in the vaccine group, it did not lead to the critical illness or by means of death. That's the good news. I will be saying something about the Russians Gamalaya, although it was not a publication into a high quality index journal, but there was a 16,000 phase 3 study population happens in their website. And when they analyze this patient who have 20 patients of COVID-19, all of them were actually from this control group and not in the vaccine group, leading to the Gamalaya success around 92%. And on the right side, I just say there's amount of information that it is also a virus vector vaccine. The price rate is very low, only $5 to $7. The Pfizer BioNTech is expensive, although it has been the first WHO approved vaccine for the emergency use authorization. The big problem is that it needs a deep freeze of -70. How about the Moderna? It's another mRNA vaccine, highly successful. Phase 3 showing 30,420 patients. 95 patients of them actually developed COVID-19. 90 of them in the placebo group. Only 5 of them developed in the vaccine group. Interesting point, and none of them has any severity. And the efficacy rate was around 95%. This is good news is that Moderna said that the freezer can be leading to -20 issues. But recently, the Moderna group actually says if the deployment started, this freezer can be also compromised to go for the normal refrigerator. Big problem is the pricing. Then the came is the Oxford AstraZeneca. The first vaccine has been showing the highlight by means of Oxford group and extraordinary people of scientists. They have the interim analysis of 11,636 patients. We all know that only 10 cases are hospitalized. 2 of them actually were severe and 1 death happened. But the interesting, the death does not happen in the part of the vaccine group, but on the part of placebo group. 2 severe reaction happens, transverse myelitis. 1 transverse myelitis was said to be due to this vaccine. Another transverse myelitis was an existence of the multiple sclerosis patient. Now, interesting phenomena happen in this study that there are 2 dosage has been happened when the trial was going on. One is the standard dose 2, means that in 28 days apart, 2 standard dose was given, and it actually shows the less amount of efficacy of 62.1. But when the 1 dose was low and the next dose was standard, look at the efficacy, it becomes 90%. Although that was a mistakenly given by manufacturer fault, but later on it gives a more impression whether 1.5 dose vaccine is enough to give a large amount of efficacy or not. Another important issue is that this gives an idea that if we consider about 2 vials, then we can cover more people rather than giving a 2 dose for the same person. So this is another area where the Oxford AstraZeneca group becomes a highlighting point. And third important point is that recently there are groups of the manufacturers saying this vaccine of the second dose can be even provided up to the 12 weeks. Means that if we consider to give the 12 weeks, the third one duration of time, the efficacy rate remains 90 to more than 90% remains so. And I will give a salute again to the Oxford scientists because they have given this vaccine for free to the Gavi as well as the WHO so that the equity of the vaccine delivery can be given. And the price remains the lowest one, $2 to $3. And another good point is that in our normal refrigerator, we can put it. A simple vaccine box in EPA schedule of Bangladesh would be a fantastic to deliver this Oxford Jenka all around the Bangladesh, including a community to hospital. Last of all, a Chinese one known as the Sinopharm. Why I'm showing this because phase 3 has enrolled 60,000 patients and one of them has 79% efficacy. Although the Sinopharm actually is the old versions of the vaccine production mechanism, the price is tremendously very high, 30 to 50 US dollar. So be careful to buy this vaccine from this one. Now, beside this, China has a lot of vaccine in the form of the Sinovac. There was a saying that Sinovac trial will be happening in Bangladesh. It never happened. There was another vaccine China and the Canada potentially has developed, the CanSino, which is similar to the Russians Gamalaya and Oxford AstraZeneca, because these are the virus vector and highly successful in the efficacy. So you can see there are a lot of area where I can say that mRNA, DNA, viral vector, inactivated, multiple candidates of vaccine is coming in the globe. And I would say that we like every vaccine to be a successful one. Why? Because if we have a lot of choices to get the vaccine and a lot of choices are there in the mechanism, then about to give you the two dosage, we can select the cost, we can select the availability, we can select the less amount of side effect profile of any vaccine to be given simultaneously in one of our patient or different patient. I was saying that in the meanwhile, these vaccines are available. Let's have a big welcome to the part of Johnson and Johnson because this is the one vaccine which will be given only single dose, and this is also adenovirus vector vaccine. I would be delighted if this vaccine come up quickly. Look at this one, Russian, although there was no papers, but the news was very highlighted suddenly when we are considering about the Moderna, Pfizer, as well as AstraZeneca. And it shows that Russian capability of the scientists as the Sputnik 5 becomes highlighting point of the viral vaccine in the territory of the group. And it shows the how to measure the vaccine efficacy, 18 point versus 1.5, leading to more than 92% efficacy. This is the papers that has been showed by the BioNTech, the side effect profile, although they are not very much severe enough. There are multiple symptoms in the form of fatigue, headache, chills, vomiting, diarrhea, muscle pain, joint pain that can develop, but neither of them is actually very serious one. But big consideration of the Pfizer BioNTech vaccine was the anaphylactoid reaction happens in some of the patient who was previously allergic or having a serious history of anaphylactoid reaction in the previously. So these are the groups must be careful before giving or choosing to give this kind of viral vaccine or the DNA or RNA vaccine. This is not a good indication to give them. You can see the efficacy, high quality against the placebo of this Pfizer BioNTech. Look at this one. And when we consider about the intention to treat analysis or per protocol analysis, the efficacy was 95% broad group, having the posterior probability of more than 0.9999. Means that vaccine efficacy is tremendously persist even after 3 to 6 months. Moderna, tremendously good one, as because 28 days, 2 doses needed in the deltoid group. The high dose of systemic adverse event, although was more than the placebo, not very much severe enough, except few of the case with anaphylactoid reaction. Look at the efficacy. Nothing about the zero COVID-19. And symptomatic COVID-11 happens in the only 11 patient. Nobody develops severe COVID-19. So this is another area where the 95% efficacy is shown by an mRNA vaccine. And what I like to mention in this respect that all the vaccine has one important finding. This means that even though some of the people actually get the symptomatic COVID-19, none of them has the severity enough to leading to the death. So that we can assume that 100% of this vaccine have the safety issue of preventing the death. But what we cannot say that whether this vaccine can prevent the symptomatic COVID-19 or not. Moderna and mRNA other vaccine did not show this in outcome. Only things that has been shown to See, the outcome was Oxford AstraZeneca. What they done, after giving this vaccine, they swab the patient so that you can see whether it can prevent the transmission or not can only be seen by this vaccine. We need to see the full report of that one when it comes back, how much percentage this vaccine can prevent the transmission of virus in the human being. It's an important territory, but in the meanwhile, efficacy analysis show tremendous amount of benefit of the Oxford AstraZeneca vaccine against the placebo or other meningeal virus. This is the papers that has been published tremendously in the Lancet. So the question remains, this injection, when it will be coming in Bangladesh? Which one is to be provided? We know that Oxford AstraZeneca is coming, but in the meanwhile, Pfizer BioNTech through the Covaxin is in the part of said to be filled. The Bangladesh will be coming soon. Maybe new one come. Who knows? Maybe the Johnson & Johnson will come later on. Who knows? Maybe the Sinopharm, Sinovac, CanSino. There are a lot of territories open up can be coming to Bangladesh in the future time. How the deployment can happen? Well, this is a big questions, big to answer, and a lot of discussion needed. Shall we need vaccine plus? Indeed. I mean, is it enough to prevent the infection or the transmission? We need plus. How about the social vaccine? Does it need to be given injection while social vaccine acts or not? So there are still a lot of questions asked about the COVID-19 future. Thank you very much for giving me a lot of time. Sorry for taking a lot of time. Thank you.
Thank you so much, sir, for your amazing presentation. Now it's time for the question and answer session. These are the questions which you asked on the comment section on the live session. So without doing any further delay, I would request Dr. Rafiqul Islam, sir, to start the question and answer session. Dr. Rafiqul Islam, sir.
Thank you, Dr. Prince, and big congratulations to Professor Amin, sir, my mentor. It's a wonderful presentation. Sir, there are so many questions to you. So without any delay, I like to ask some question to you. So according to you, which one is the best vaccine? You think it's a double vector Sputnik 5 or AstraZeneca vaccine from Oxford or BioNTech, Pfizer, Moderna or Johnson & Johnson? So what do you think, sir?
Okay, thank you very much. I think this cannot be just given a simple answer, this one is better than that one. এটা আসলে এভাবে বলা উচিত হবে না, কারণ এক একটা ভ্যাকসিন এক একভাবে দেখেন আপনারা কাজ করছে। সো এবং এভরিওয়ান হ্যাজ এ ইউনিক মেকানিজম। এমআরএনএ ভ্যাকসিনের যেমন একটা ইউনিক মেকানিজম আছে, ভাইরাস ভেক্টর একটা ইউনিক মেকানিজম, সো অলসো ফর দ্য ইনঅ্যাক্টিভেটেড। আমি বলবো যে ইফিকেসিলি আপনারা যদি চিন্তা করে থাকেন, তাহলে দেখেন প্রায় সবগুলোই কিন্তু মোর দেন 90% ইফিকেসি রেট আছে। সো এটা ট্রিমেন্ডাস। সো এই জন্য আমি মনে করি না যে কোনো একটা ভ্যাকসিন আরেকটা ভ্যাকসিন থেকে বেটার হবে, কিন্তু আমাদেরকে দেখতে হবে আমাদের বাংলাদেশের যে পার্সপেক্টিভে কোন ভ্যাকসিনটা আমাদের কস্ট ইফেক্টিভ হবে, কোন ভ্যাকসিন দেওয়াটা আমাদের জন্য ইজিয়ার হবে, কোন ভ্যাক্টরটা আমাদেরকে ডিপ্লয়মেন্ট করাটা ইজি হবে। ডাবল ভ্যাকসিনের দুইটা দেওয়াটা আমাদের জন্য ভালো হবে নাকি সিঙ্গেল ডোজ দিলে বেটার হবে? আমরা কি সহজ একটা রেফ্রিজারেটর রাখাটা আমাদের জন্য ইজি হবে? একটা ভ্যাকসিন ক্যারিয়ার দিয়ে দিলাম, তো এটা নিয়ে গিয়ে একটা গ্রামের দেশে মানুষের গ্রামের জায়গাতেও আমরা দিতে পারবো, গ্রামের একটা হাসপাতালও দিতে পারবো কিনা? নাকি আমাদের একটা বড় সড়ো ফ্রিজ লাগবে, একটা পিজা বক্স ডেলিভারির মতো একটা -70 সিস্টেম লাগবে ফাইজার বায়োনটেকের জন্য অথবা মডার্নের জন্য? সবকিছুকে আসলে কনসিডার করতে হবে। এবং শুধু তাই নয়, আমাদের মানুষরা কি ভ্যাকসিন দেওয়ার জন্য প্রস্তুত কিনা, আমাদের মানুষজন কি অ্যাডাল্ট ভ্যাকসিন দিতে অভ্যস্ত কিনা, বয়স্ক বৃদ্ধরা দিবে কিনা। কারণ আমাদের এখানে অনেক ধরনের স্টিগম্যাটাইজেশন আছে, যে কেউ বলতে পারে আমাকে না দিয়ে আমার নাতিটাকে দেন, তাই না? তো অনেক বিষয়গুলো আছে। আমি মনে করি যে many of the vaccine combination can be highly. ধন্যবাদ।
Thank you, sir. How do you think, sir, about how might mutation affect vaccine?
এটাও একটা খুব ভালো প্রশ্ন। এখন পর্যন্ত যে মিউটেশন গুলো এর আগে প্রথম দিকে আমি তো বলেছি, দেখেন যে প্রায় 12,000-এর উপর মিউটেশন হয়েছে এবং এই মিউটেশনের ম্যাক্সিমাম অনেকগুলোই ছিল কিন্তু স্পাইক প্রোটিনের বাইরে। সুতরাং এগুলো কোনো কনসিডারেশন না, কারণ স্পাইক প্রোটিন দিয়েই কিন্তু আপনার খুব বেশি ফিটিং হচ্ছিল এবং সো দ্যাট নিউট্রালাইজিং অ্যান্টিবডি গুলো এটার এগেনস্টে ডেভেলপ। কিন্তু যখনই স্পাইক প্রোটিনের এগেনস্টে ডেভেলপ হওয়া শুরু হলো মিউটেশন, তখনই প্রশ্নটা আসা শুরু করবে যে ভ্যাকসিন কি তাহলে সাকসেসফুল হবে। আমি বলবো যে কয়টা মিউটেশন আপনি দেখবেন যে স্পাইক প্রোটিনেও হয়েছে, এটা কি আপনার তার কনফরমেশনাল চেঞ্জ করে ফেলতে পারছে কিনা। তার মানে আপনি যদি মিউটেশন করে প্রোটিনটার স্ট্রাকচারটাকে এমনভাবে চেঞ্জ করে ফেলেন যে সে আর ঠিকমতো ফিট হতে পারছে না, অথবা কোনো জায়গায় ACE2 রিসেপ্টরের গায়ে লাগে পাচ্ছে না, তখনই কিন্তু প্রশ্নটা আসবে যে আমাদের ভ্যাকসিনটা কি আসলে সাকসেসফুল হবে কিনা। এখন পর্যন্ত যতগুলো মিউটেশন হয়েছে আর কি স্পাইক প্রোটিনে, তার কোনোটাই কিন্তু এত কনফরমেশনাল স্ট্রাকচারাল চেঞ্জ অফ প্রোটিন দেখাতে পারেনি। সো দ্যাট এখন পর্যন্ত আমরা বলতে পারবো যে ভ্যাকসিন যেগুলো আছে স্টিল দেন এটা সাকসেসফুল হতে পারে। তবে যদি ভবিষ্যতে কোনো মিউটেশন এমন হয় যে কনফরমেশনাল প্রোটিন স্ট্রাকচার চেঞ্জ হচ্ছে, আমাদের ACE2 রিসেপ্টরের সঙ্গে ফিট হচ্ছে না, তখন আসলেই কিন্তু ভ্যাকসিন এফিকেসি নিয়ে প্রশ্ন চলে আসবে।
Sir, another question for Amin Hassan, that you and me both are affected by COVID. Should we both get vaccine?
The answer is yes. তার কারণটা হচ্ছে যে COVID-19 হওয়ার পরেও এই ভাইরাস কিন্তু ডিফারেন্ট মিউটেশন হচ্ছে, এবং আমি কিন্তু একটা স্লাইডে দেখিয়েছি, দেখেন যে 1 বছর পরবর্তী উহানের যে ভাইরাস ছিল সেই ভাইরাস আর সেই ভাইরাস নেই। সুতরাং ওই ভাইরাস দিয়ে আমি মোহাম্মদ রফিকুল অথবা রফিকুল ইসলাম অথবা আমাদের সম্মানিত প্যানেলিস্ট যে কেউ কিন্তু আবার এফেক্টেড হতে পারেন, ইভেন দো আমরা আগেও এফেক্টেড হয়েছি। এই জন্য ভ্যাকসিন ইজ আ মাস্ট। সেকেন্ড ইস্যু, যে অ্যান্টিবডি আমাদের শরীরে ডেভেলপ হয়েছে বিকজ উই আর স্টিল অ্যালাইভ, আমি এবং রফিক, this antibody may not persist for long after 3 to 6 months, as because it's a new virus, তাদের নিউ ইমিউনিটি, অনেক কিছু প্রশ্ন এখনো অজানা যেটা দীর্ঘ মেয়াদী অ্যান্টিবডি থাকবে কিনা। এই জন্য ভাইরাস ইনফেক্টেড হওয়ার পরও ভ্যাকসিন নেওয়া উচিত হবে বলে আমি মনে করি।
Sir, suppose I am affected by a virus, so I got one shot of vaccine, and within after 8 to 10 days or 15 days, I got infected by the virus. Should I get the second dose?
The big question is that যে আপনি ভ্যাকসিন নেওয়ার ফার্স্ট ডোজটা পরে কি 7 থেকে 8 দিনের মধ্যে আবার ইনফেক্টেড হয়ে যেতে পারেন কিনা। আমি এই জায়গাটা বলবো যে পেপারস গুলো পাবলিশ হয়েছে, ইন্টারেস্টিং ফেনোমেনা হচ্ছে তাদের 7 দিনের মধ্যে আসলে কারো কোনো পরিমাণ আপনার ভাইরাল ইনফেকশন হয় নাই, এবং যখন অ্যাকুইট ভাইরাল ইনফেকশন হয়ে যাবে ওই সময়টাতে আসলে কোনো ভ্যাকসিন দেওয়া যাবে না। ওই সময়টা পার হয়ে যাওয়ার পরে আপনি অবশ্যই সেকেন্ড ডোজ ভ্যাকসিনও দিতে পারবেন, কোনো সমস্যা নেই আসলে।
Sir, question is, can vaccinated people still spread the virus?
This is the important issue, as because Moderna বলেন, ফাইজার বায়োনটেক অথবা আদার যেগুলো কারেন্টলি ভ্যাকসিন, এগুলো কেউ কিন্তু দেখেনি যে ভ্যাকসিন দেওয়ার পরে গিয়ে একটা ভাইরাস ট্রান্সমিশন বন্ধ করতে পারে কিনা, এক্সেপ্ট দ্য অক্সফোর্ড অ্যাস্ট্রাজেনেকা। কারণ আপনি দেখবেন ওরা 7 দিন অথবা 14 দিন পরে দেখেছে যে কাদের কোভিড হয়েছে কাদের হয়নি, সিমটোম্যাটিক কোভিড কিনা, তাই না? তাহলে আপনি তো ট্রান্সমিশনের জায়গাটা দেখলেন না। কিন্তু অক্সফোর্ড অ্যাস্ট্রাজেনেকা যেটা করেছে যে প্রথম এবং 28 দিন দেওয়ার পরে ওরা নেজাল সোয়াব নেওয়া শুরু করেছে। তাহলে আপনি যদি তাতে নেজাল সোয়াব নেওয়া শুরু করেন, তাহলে ভাইরাস ডিটেকশনটা আপনি করে ফেলতে পারলেন, মিনস দ্যাট এই রোগীটাকে আসলে ট্রান্সমিটেবল করছে কিনা এটা পেয়ে যাবে। তো ওই অ্যানালাইসিসটা পুরোটা এখনো এইজ ভিত্তিক আসে নাই, আসলে তখন হয়তো আমরা বলতে পারবো যে এটা ট্রান্সমিশন প্রিভেন্ট করে কিনা। কিন্তু এখন পর্যন্ত যতগুলো ভ্যাকসিন আছে তাতে কোনোটা দেখায় নেওয়া যায়নি যে ট্রান্সমিশন প্রিভেন্ট করতে পারে।
Sir, next question is, the percentage of population need to get vaccinated to get herd immunity?
এটা খুব ভালো একটা প্রশ্ন। এটা নিয়ে আমি বলবো যে অনেক ধরনের দ্বিধাদ্বন্দ্বতা আছে, কিন্তু আসলে কোনো একটা পপুলেশনে যখন অনেক বেশি হাই প্রিভেলেন্স হয়ে যাবে তাদের ক্ষেত্রে 80% ইজ এনাফ টু গেট এন হার্ড ইমিউনিটি। কিন্তু যদি প্রিভেলেন্স কম থাকে কোনো একটা জায়গাতে, সেক্ষেত্রে কিন্তু এর থেকেও বেশি পরিমাণ পার্সেন্টেজ, ইভেন 90% অফ দ্য পপুলেশনকে আপনার আসলে কাভারেজ দেওয়ার দরকার হতে পারে ফর দ্য ডেভেলপিং হার্ড ইমিউনিটি।
Thank you, sir. Thank you very much. This is end of question answer session. Now time for panelist. I will talk with Professor Dr. Muhammad Abdul Kalam Azad sir, former head Department of Genetic Engineering and Biotechnology, Shahjahan University of Science and Technology, Silet. Sir, may I request you to say a few words regarding the program as well as your opinion regarding virus to vaccine?
Thank you so much. First of all, I would like to congratulate Professor Amin for his outstanding presentation, deliberation, excellent. And I think many things he already mentioned and clearly mentioned. সো আমি যেটা আর কি একটু সামান্য বলতে চাই যে আমাদের মধ্যে যে কিছু ওরিনেস কাজ করে যে আসলে আমাদের মধ্যে মিউটেশন অনেক আছে। অলরেডি উনি দেখিয়েছেন যে 12,700 বা তার চেয়েও আরো বেশি মিউটেশন আসছে। আমাদের দেশেও কিছু সিকোয়েন্স করা হয়েছে এবং সেখানেও আমরা মিউটেশন পেয়েছি। সুতরাং মিউটেশন পাওয়ার মানেই কি যে আমরা ওরিড হয়ে যাব যে আমাদের এই ভ্যাকসিনগুলো কাজ করবে কিনা। আসলে মিউটেশন কোন জায়গায় হচ্ছে, কি করছে, সেটা আমাদের দেখার বিষয়। সো ভ্যাকসিনের যে বিষয়টা, সেইটা আসলে ডিপেন্ড করছে ভাইরাল ফ্যাক্টরের উপরে, নট দি হোস্ট ফ্যাক্টর। সো ভাইরাল ফ্যাক্টরের উপরে যদি এটা ডিপেন্ড করে, তাহলে ভাইরাসের কোন জিনিসটাকে আমরা কাউন্ট করছি। আমাদের প্রেজেন্টেশনে কিন্তু প্রফেসর রুবেত আমিন ভালোভাবে উল্লেখ করেছেন যে আসলে স্পাইক প্রোটিনটা কি টার্গেট করা হচ্ছে। বেশিরভাগ ভ্যাকসিনেরই টার্গেট হয়, সেটা এমআরএনএ ভ্যাকসিন হোক, যেমন দেখা গেছে এই পর্যন্ত 9টি ভ্যাকসিন অ্যাপ্রুভাল পেয়েছে। এর মধ্যে 2টি এমআরএনএ ভ্যাকসিন, 4টি অ্যাটিনুয়েটেড ভ্যাকসিন, একটা পেপটাইড ভ্যাকসিন, আর 2টা হলো ভাইরাল ভেক্টর ভ্যাকসিন, রাইট? এবং দেখা গেছে যে ক্লিনিক্যাল ট্রায়ালে আছে আরও 42টি এবং ডেভেলপমেন্ট ফেজে আছে আরও 240টি এলো ডেটাবেস। তো অধিকাংশ ক্ষেত্রেই দেখা গেছে যে স্পাইক প্রোটিনটাকে সেটা টার্গেট করা হয়। এটা যেই টাইপেরই ভ্যাকসিন, মানে অ্যাটেনুয়েটেড ভ্যাকসিন ছাড়া, বিশেষ করে যদি এমআরএনএ ভ্যাকসিন এবং পেপটাইড ভ্যাকসিন হয়, ডেফিনেটলি পেপটাইড ভ্যাকসিনের বেশিরভাগ টার্গেটই হলো এই স্পাইক প্রোটিনকে। তাহলে মিউটেশন যদি আর কি দেখা যায় যে এই স্পাইক প্রোটিনকে কনফরমেশনাল চেঞ্জ আনতে পারে, তাহলে সেটা শুধুমাত্র সম্ভব। সুতরাং তার যে বাইন্ডিং সাইটটা, অ্যান্টিজেন এবং অ্যান্টিবডি যে তাকে নিউট্রালাইজ করার জন্য যে বাইন্ডিং সাইটটা, সেখানে যদি এফেক্ট না করতে পারে, তাহলে হয়তো দেখা যাবে যে সেই ভ্যাকসিনের এফিকেসি নষ্ট হবে না, সেটা কাজ করবে। তবে এখানে একটা জিনিস হইল যে এই ভাইরাসের রিকম্বিনেশন ক্যাপাবিলিটি অনেক বেশি আছে অন্যান্য ভাইরাসের চেয়ে। কেননা দেখা গেল যে তাদের যে জেনেটিক ডাইভার্সিটি, জেনোম রিকম্বিনেশন ক্যাপাবিলিটি এবং হিউম্যান এবং অ্যানিমেলের যে ইন্টারফেসের যে ক্যাপাবিলিটিগুলো আছে, এইটা কম্পারেটিভলি অন্য ভাইরাসের চেয়ে বেশি। এবং করোনা ভাইরাসের যে আরও 6টা রূপ এই পর্যন্ত, এই SARS-CoV-2 ছাড়া অন্য যে 6টা ভাইরাসের রূপ দেখেছি আমরা, দেখা গেছে তাদের চেয়ে অনেক বেশি। যেমন দেখা গেল যে উদাহরণস্বরূপ যদি আমরা বলে থাকি যে স্পাইক প্রোটিন, দেখা গেছে যে SARS-CoV-1 অর্থাৎ সার্স যেটা করেছিল এবং এখন যে SARS-CoV-2 করছে, তাদের মধ্যে কিন্তু এই স্পাইক প্রোটিনের যে আইডেন্টিটি, এটা কিন্তু 99%, অনলি 1% ডেভিয়েট করছে। এবং যে মিউটেন্টগুলো আমরা দেখছি, সেখানে কিন্তু দেখা যাচ্ছে যে 99.9% পর্যন্ত কিন্তু আইডেন্টিটি ক্যারি করছে। তাহলে সার্সের সাথে সে 99 আইডেন্টিটি ক্যারি করছে, বাট তার বাইন্ডিং ক্যাপাসিটি কিন্তু দেখা যাচ্ছে যে 10 to 20 টাইমস মোর দেন দি সার্স CoV-1 ভাইরাস, ঠিক আছে? সো কোন জায়গায় ভাইরাসটার এটা মিউটেশনটা হচ্ছে, ইট ইজ ভেরি ভেরি কনসিডারিং। আর আমি আরেকটা পয়েন্ট বলতে চাই, যেখানে কনফার্মেশনাল চেঞ্জ বা যে এই যে রিকম্বিনেশন যে কথাটা আমি বলেছি, এখানে 5টা যে স্ট্রাকচারাল প্রোটিন আছে, এটা প্রফেসর রুবেত আমিন উল্লেখ করেছেন। স্পাইক প্রোটিন, এম প্রোটিন, অ্যান প্রোটিন, হ্যাঁ, ক্যাপসিড প্রোটিন এবং পলিপ্রোটিন আছে, এগুলো স্ট্রাকচারাল প্রোটিন। এছাড়া আরেকটা কালপিট প্রোটিন হলো যে ORF8, it is the main responsible for recombination. এইটা বেশ কয়েকটা ভালো নেচার সহ আরো বেশ কতগুলো জার্নালে কতগুলো আর্টিকেল এসেছে যে দিস প্রোটিন ইজ রেসপন্সিবল ফর রিকম্বিনেশন। সুতরাং আমাদের যে ভেরিয়েন্টগুলো আছে বিভিন্ন রিজিয়নে, যেমন কতগুলো ভেরিয়েন্ট অলরেডি উল্লেখ করা হয়েছে প্রেজেন্টেশনে, এবং তার ওল্ড ভার্সানে দেখা গেছে কিছু কিছু দেখা যাচ্ছে আমেরিকা, ইউরোপে এক টাইপের ভেরিয়েন্ট, এগুলো হলো এ। তারপরে দেখা গেল যে আমাদের এশিয়ার যে রিজিয়নে সেটা বি। সুতরাং এ ধরনের A, B, C এরকম কতগুলো টাইপ আছে, এবং রুবেত আমিন আরও ভালোভাবে দেখিয়েছেন। সুতরাং এখানে যদি এরকম কোনো ঘটনা ঘটে যে এই রিকম্বিনেশনের কারণে যদি দেখা যায় একাধিক ভেরিয়েন্টের যদি রিকম্বিনেশন, এটা হতেই পারে, সেটা হিউম্যানও হতে পারে অথবা অন্য কোনো অ্যানিমেলের মধ্যে সেটা হতে পারে। যেমনি করে সায়েন্টিস্টরা এখনও আর কি মোটামুটি বলে যাচ্ছেন, এবং আমরা অনেকটাই কনভিন্সড যে আসলে এটা রিকম্বিনেশনের মাধ্যমেই দেখা গেছে যে বেড থেকে সেকেন্ডারি একটা হোস্টের মধ্য দিয়ে তারপর হিউম্যানের মধ্যে এসেছে, যার কারণে তার যে এই যে ইনফেক্টিভিটি ক্যাপাবিলিটিটা অনেক বেশি এবং নোবেল। সুতরাং সেটা কিন্তু দেখা গেছে যে এই ভেরিয়েন্টগুলোর রিকম্বিনেশন কিন্তু হতে পারে হিউম্যানের মধ্যে, যদি দেখা যায় যে সে একাধিক ভেরিয়েন্টে যদি সে ক্যারি করে, তাহলে দেখা যাবে যে বিভিন্নভাবে সেই রিকম্বিনেশনটা হতে পারে। এবং কিছু ডিলিশনের কথা বলা হয়েছে, সেই ডিলিশনটাও দেখা যাবে যে যদি এরকম হয় যে এই রিকম্বিনেশনকে সে যদি অ্যানেন্স করে, তাহলে হয়তো নিউ ভেরিয়েন্ট আসবে। সেই নিউ ভেরিয়েন্ট যদি এরকম হয়ে যায় যে আসলে তার স্ট্রাকচারাল প্রোটিনকে সে চেঞ্জ করে দিতে পারছে, তার স্ট্রাকচারকে টোটালি না, বাট তার বাইন্ডিং যে সাইটটা আছে, অ্যান্টিজেন এবং অ্যান্টিবডির যে বাইন্ডিং সাইট আছে, সেটা যদি চেঞ্জ করে দেওয়ার ক্যাপাবিলিটি সে অর্জন করে, তাহলেই শুধুমাত্র যেই ভ্যাকসিনগুলো এখন আসছে সেগুলো কাজ করবে না, অথবা এই ভ্যাকসিনগুলো কাজ করবে। সুতরাং আমাদের দেখতে হবে যে আসলে যে চেঞ্জগুলো হচ্ছে, সেই চেঞ্জগুলো আসলে সেই অ্যান্টিজেন অ্যান্টিবডি বাইন্ডিং যে স্পেসিফিক সাইটটা আছে সেইটাতে হচ্ছে কিনা। যদি না হয়, তাহলে আমাদের ওরিড হওয়ার কোনো কারণ নেই। আর ইন্টারভেনশন নিয়ে উনি চমৎকারভাবে বলেছেন, ওইখানে আমি একটু কথা বলতে চাই, কারণ ইন্টারভেনশন আসলে ডিপেন্ড করে আমাদের হোস্ট এবং ভাইরাস, এই দুইটা ফ্যাক্টরের উপরে কিন্তু ইন্টারভেনশনটা কাজ করবে। সুতরাং ইন্টারভেনশনের জন্য সবচেয়ে বেশি টার্গেট হলো সায়েন্টিস্টদের কাছে যে এটাতে ঢুকতে দেবো কেন আমি, যদি ঢুকে যায় তাহলে কিন্তু আমার জন্য কষ্টদায়ক হয়ে যাবে। কারণ কি, ভাইরাস যদি আমি মারতে চাই, তাহলে আমার হোস্ট সেলকেও কিন্তু মারতে হচ্ছে। কেননা সে হোস্টের অ্যাপারেটাসটাকে চমৎকারভাবে গলগি, যেমন রুবেতামিন দেখিয়েছেন কিভাবে গলগি অ্যাপারেটাসে গিয়ে যে রাইবোজোমকে ইউজ করে চমৎকারভাবে সে তার প্রোটিনগুলো তৈরি করে ফেলছে এবং প্যাকেজে এসে বের হয়ে আসছে সেলকে ডিস্ট্রয় করে দিয়ে। সুতরাং আমাদের টার্গেট হবে যে আসলে সে যাতে ঢুকতেই না পারে। তাহলে ঢুকতেই যদি না পারে, তাহলে আমাকে টার্গেটটা হবে তার বাইন্ডিং সাইটটা, অর্থাৎ ACE2। এবং আরেকটা নিউ অ্যাসিস্ট্যান্স পাওয়া গেছে, আপনারা হয়তো জানেন যে NRP, নিউরোপিলিন 1 নামে আরেকটা রিসেপ্টর সায়েন্সে পাবলিশড হয়েছে। সুতরাং আরও হয়তো রিসেপ্টর সেখানে থাকতে পারে, অথবা এই রিসেপ্টরকে অ্যাসিস্ট করতে পারে এই ধরনের প্রোটিন কিন্তু থাকতে পারে হোস্টের মধ্যে। সুতরাং সেখানে আমাদের সেই টার্গেটগুলো দেখতে হবে। এবং এখানে আরেকটা ইন্টারেস্টিং বিষয় হচ্ছে, রুবিত আমিন একটু উল্লেখ করেছেন যে আসলে ডিসক্রেডিটলি অনেক স্টাডি হয়েছে, হিউজ স্টাডি হয়েছে সারা বিশ্বের মধ্যে, বাট অনেক স্টাডি দেখা যাচ্ছে আসলে কোঅর্ডিনেশনের যথেষ্ট অভাব আছে, ইন্টিগ্রিটির অভাব আছে। সমন্বয় করলে দেখা গেছে যে এক এক রকমের মেসেজ ক্যারি করছে। সুতরাং এখানে আমরা যেটা ফিল করি এবং সাজেস্ট করি, সেটা হলো একটা লঙ্গিচুডিনাল স্টাডি করতে হবে, যেটার মধ্যে দেখা যাবে যে আমাদের গ্রুপগুলোকে নিতে হবে হেলদি পারসন এবং ইনফেক্টেড পারসন। হেলদি পারসন এর ক্ষেত্রে দেখা যাবে যে আমাদের এই যে রিসেপ্টরের যে এক্সপ্রেশন দেখতে হবে, প্লাস এখানে শুধু এই রিসেপ্টর না, তার অ্যান্টি অ্যাসোসিয়েটেড যে প্রোটিয়েজগুলো আছে, যেমন S1 S2, কিন্তু প্রফেসর রুবেতামিন চমৎকারভাবেই দেখিয়েছেন কিভাবে আইসা সেটা বাইন্ড করতে পারে। সুতরাং সেই অ্যান্টি অ্যাসোসিয়েটেড প্রোটিনগুলোর জিনগুলোর এক্সপ্রেশন এবং এই রিসেপ্টরের এক্সপ্রেশন আমরা যেমনি করে হেলদি পার্সনের মধ্যে দেখতে হবে, এমনি করে ইনফেক্টেড পার্সনের মধ্যে দেখতে হবে যারা নাকি কমরবিডিটি আছে এবং উইদাউট কমরবিডিটি আছে। সুতরাং এই তিনটা গ্রুপ আমাদের একটা কনসার্ন বিষয়। নট অনলি দ্যাট, দেখা যাবে যে আমরা যদি ইন্টারভেনশনের চিন্তা করি, তাহলে অবশ্যই আমাদের যে ইমিউন কম্পোনেন্ট যা আছে, ইফেক্টর সহ, দেখা যাবে যে ইমিউন রেসপন্সের সাথে যে জিনগুলো ইনভলভ আছে, তাদের এক্সপ্রেশন এই তিনটা গ্রুপের মধ্যে কেমন হচ্ছে, সেটা আমাদেরকে কনসিডারেশনে আনতে হবে। এবং এই শুধুমাত্র জিনগুলো আনলেই হবে না, আরও যে ইমিউন সেল আছে, যে কম্পোনেন্টগুলো আছে, সেগুলো কিন্তু এই তিন গ্রুপের মধ্যে কনসিডারেশন আনতে হবে। সুতরাং এই ধরনের যদি লঙ্গিচুডিনাল স্টাডি যদি আর কি লিড দেওয়া যায়, তাহলে দেখা যাবে যে আমরা হয়তো সাকসেসফুল এই ইন্টারভেনশন হয়তোবা আশা করতে পারি। সুতরাং ভ্যাকসিন নিয়ে আমরা মনে এই মুহূর্তে ওয়ারিড হওয়ার কোনো কারণ নেই। তবে রুবেতামিন যেটা নাকি উল্লেখ করেছেন যে আসলে কোনটা আমাদের দেশের জন্য ফিজিবল, ইট ইজ ভেরি ভেরি ইম্পর্টেন্ট। আমি একটা ছোট্ট উদাহরণই দিচ্ছি, আমার নিজের কথা। আমার ওয়াইফ ডাক্তার, সেও কিন্তু ভ্যাকসিন নিয়েছিল হেপাটাইটিস বি এর, সে নিয়েছিল ফ্রি এই ময়মনসিংহ মেডিকেল কলেজে, আর আমি নিয়েছিলাম কিনে। যখন আমরা অ্যান্টিবডি টাইটার দেখেছি, তখন দেখলাম যে আমার মধ্যে প্রচুর অ্যান্টিবডি তৈরি হয়েছে, বাট আমার ওয়াইফের সিরামের মধ্যে কোনো অ্যান্টিবডি নাই। কেন নাই? সেটা ভ্যাকসিন কিভাবে নষ্ট হইলো, কি হইলো, কেন হইলো, এখানে অনেক কোশ্চেন আছে। ওকে, সো এই যে প্রিজার্ভেশনের বিষয়টা, ইট ইজ ভেরি ভেরি ক্রিটিক্যাল ফর বাংলাদেশ। আই থিঙ্ক সুতরাং এখানে অবশ্যই আমাদেরকে স্ট্র্যাটেজি সেট করতে হবে যে আসলে আমরা কোন ভ্যাকসিনটা নেব, কিভাবে আনবো, দাম প্লাস প্রিজার্ভেশন ইজ ভেরি ইম্পর্টেন্ট ফর বাংলাদেশ, এটা আমি পার্সোনালি ফিল করি। ঠিক আছে, সুতরাং আমার মনে হয় আমি বেশি সময় নিয়ে যাচ্ছি এই মুহূর্তে, আর হয়তো আর কি আমি অ্যাড করতে চাচ্ছি না। ধন্যবাদ।
Sorry, sir. There's been technical difficulties with our Rafiqul Islam, sir. I would like to sir.
Thank you. So the little interruption is there. Now I will humbly request Professor Muhammad Ismail Patwary sir, who is Principal and Professor of Medicine, Sylhet Women's Medical College, to comment regarding the program. Before that, I will cordial thanks to Professor Muhammad Abdul Kalam Azad sir. Thank you, sir. Thank you for your nice comments. Professor Muhammad Ismail Patwary sir.
Bismillahirrahmanirrahim. First of all, I congratulate Professor Robert Amin for his excellent presentation. And in this situation, this presentation is highly demanded because we are going to vaccinate our population, and from the virus to vaccine. This is a very time-demanding topic, and Professor Robert Amin already mentioned all the pros and cons of his talk. And the most important thing is that that is the timeline of symptoms of severe coronavirus infection. That is very important, as we have seen from the presentation, that is the onset of symptoms actually starts from the onset up to 7 days, and from the first week, that is the breathlessness or dyspnea actually occurs in about 40% of cases, and the more severe cases actually occurs after 10 days. And with the people, we have seen many of our patients as well as our colleagues are getting admitted with mild symptoms, but they are not requiring any oxygenation because their oxygen saturation is good. But due to fear or due to phobia or due to compassionate use, they are actually getting all sorts of drugs like antibiotics as well as antiviral drugs as well as anti-inflammatory, that is dexamethasone and others. But in this presentation, very nicely he has mentioned that when to use antiviral drugs, when to use that is anti-inflammatory drugs, steroids, and in the very severe cases when there is a when there is a cytokine storms, when to use the other drugs. So judicious use of drugs is very important, and with the clinicians as well as the physicians should follow this rule. Besides, the technology that has been developed for development of vaccine, that is RNA vaccine or attenuated vaccine or vector-borne vaccine, that is also important aspect for the vaccine development. And in a very short time, we are also going to get the vaccine. But the important things is that in our country, which one we should choose. And Professor Rubidaman already mentioned very nicely that those vaccine which we can transport easily in our usual cold chain maintaining in the API chain, that should be collected. Otherwise, if we get vaccines we have to preserve at the minus 70 to 20 degree centigrade, that will be very difficult, and whether efficacy will retain, that will be doubtful. As already Professor Abdul Kalam Azad has already mentioned, in one case there is enough antibodies, and in another case there is little antibodies. So this aspect, vaccine transport, vaccine preservation, and that is also important. But overall, we should also follow the general rules. That is very important. because we have seen in our social life the maximum of our people are not actually using the mask, as well they are not maintaining the social distancing, as well as the other hand washing and others. So this should give mass emphasis. Vaccine will help us, but the things that we should follow, that should be actually mandatory for all people. And already we have seen from our presentation that vaccine, it is not clear whether they will prevent the transmission. Severity will be reduced, no doubt, but how long it will give protection, it is not still decided. Whether it will give the lifelong immunity, whether it will give the 1 year booster should be given, that is not still clear. Though we have seen that 2 dose should be given at interval of 3 weeks or 4 weeks, but how long immunity will persist? So this should also be considered. And in our aspect, we should also consider whether the vaccine we are getting from which source and how we are preserving this. And we should also set the priority, those who should get the vaccine first, and this order should be followed. So I again thank the Professor Amin for his very excellent presentation. I also convey my gratitude to Professor Nazmul from Nazmul for his very judicious selection of the topic, which is very time demanding. And I hope all our participants will be benefited from this presentation. So thank you very much for your patient sharing.
Thank you, sir. Thank you, Professor Ismail Patwary, sir, for your kind remarks. Now, may I request Professor H.A.M. Nazmul Ahasan, who is Governor of ACB Bangladesh chapter, for his kind remarks and conclude the session. Professor H.A.M. Nazmul Ahasan, Governor ACB Bangladesh chapter.
Assalamu alaikum.
There's some
Thank you,
interruption in
Dr.
the
Rafiq.
internet.
Am I audible?
Yes. Yes.
Thank you, Dr. Rafiq. Possibly we are almost at the end of our session. And at first, I want to congratulate Professor Amin for his splendid presentation. Undoubtedly, he is one of the trusted and favorite teacher and favorite speaker in our country, not only medicine of whole Bangladesh. And he is very loving to me for defined reason. For the last couple of months, I was looking to give him some topic, but due to some reasons, it was not possible. But this time, another characteristic of his is that he cannot say no. So this time when I said that you are to give a talk on virus to vaccine, so this is a huge topic. For the last 13 months, the whole world is almost paralyzed with this virus, with the tiny virus. And during all health system is exhausted and paralyzed. And 2 months back, when there was a declaration that a vaccine has been invented, almost all were happy. And before USA, UK started giving immunization or vaccination first. But unfortunately, they also first declared that they have discovered one strain which is very dangerous, 70% more transmission and transmissible, but although not deadly, but it is very highly infectious. It is difficult to imagine and believe that at this moment, for the last 40 days, more than 1 lakh people are being affected in USA for the last 40 days daily. And at this moment, 30,000 people are hospitalized in UK. Can you believe? In our country, for the last 10 days, we are having less than 1,000 cases per day. But in UK, 30,000 people are hospitalized. And in USA, more than 1 lakh people are being hospitalized daily for the last 40 days. So it is a havoc for whole world. We are hopefully we are having our vaccine within couple of weeks. So at this moment, at one arm we are having an emerging virus, at the other end we are having a virus vaccine. So a lot of things, lot of questions might be unanswered. What would be the immunity status, what will be the herd immunity, how much doses will be needed, whether every year we have to give this type of vaccine. So a lot of questions are there. So Professor Rubithamin, he has tried to give a lot of information from the start of the virus and from the treatment part, and also has ended up to vaccine. But if 3 hours is given, possibly it will not be sufficient for him also. So he has tried to give a splendid lecture within this 1 hour. Definitely, including myself, almost all of us has been benefited. Thank you, Professor Ribet. I have also requested Professor Abul Kalam Azad. He is a former dean School of Life Science and also former head of the department Genetic Engineering, Shah Jalan University. He is our guest panelist. He has given a lot of information what might happen with this new virus. Hopefully it will not be harmful, and also possibly vaccine will be okay with this if this emerging virus also comes in our country. And I am also thankful to Professor Ismail Patwary, who is also one of the important clinician and educationist and researcher of our country. He is principal and head of the department and president, Society of Infectious and Tropical Disease. I congratulate all of you for your contribution. Finally, Dr. Rafiqul Islam, he is moderator and also secretary to SCP chapter. And I want to congratulate also Dr. Prince. He is always with us. He is contributing a lot in SCP chapter. But we are organizing this on behalf of SCP chapter Bangladesh, but our parent organization is Bangladesh Society of Medicine. They are always supporting with us to arrange this program. So on behalf of SCP chapter Bangladesh, on behalf of Society of Medicine, I think all of listeners all are very, very much benefited. And next week, hopefully, we will arrange another program on adult immunization and also what will happen with upcoming vaccination of COVID vaccine. I invite you and request you also to join that program. I again congratulate Professor Rubet Amin, Professor Ismail Patwary, Professor Abul Kalam Azad, Dr. Rafiq, and Dr. Prince, and everybody. Thank you very much. Thank you again.
Sadly, we have come to the end of today's program. As always, we have learned so many important things from Sir today. Many thanks to the speaker, the chair, the panelist, last but not the least, the moderator, Sir, for managing time for this program from their very busy schedule. I would like to thank all the audience who were with us throughout the event, especially those who have asked very interesting questions. Hope you got your answer. If you joined late or couldn't see the whole program, there is no need to be worried. You will find the whole program on YouTube right after the live session finishes. Our Health Talk episode 11 will be held on 21st January, where Dr. Muhammad Azul Haq Azad sir will discuss on the topic adult immunization and upcoming COVID-19 vaccination. So, see you all in the next episode. Until then, good night and take care.